know it's on.
Yeah. Welcome. I want to welcome you to our final Lucent Symposium for the year. This is the end of our first, sort of planning and building year for Lucent. And I want to update you briefly on what we're doing with Lucent the rest of this summer and then going forward. This year has been our year to build a community of interest and practice, and we've had monthly symposia on different primary care topics and leadership topics relevant for primary care. We have now recruited a cohort of residents from medicine, peds, med-peds, and family medicine. One full-time fellow for the coming year, that's Meredith McNamara from peds, will be a full-time Lucent fellow, and a cohort of faculty from those departments and a couple of community-based faculty that'll be working with us in the coming year to build their leadership skills. Now that group will be meeting twice a month starting in September. We'll do some preliminary work over the summer, but that group will start meeting twice a month to do hands-on workshops, build their own skills, and work in their practices for transformation in primary care. We will continue to have the larger open symposia once a quarter next year. So we'll have quarterly sessions open to all our students and everybody, and then we'll have more frequent workshops for the Lucent cohort. So thank you for your support and interest, and please let us know if you have further suggestions or if you want to find out more about the Lucent program. So I want to introduce to you Dr. Rogers. Denise Rogers is here with us today as our Lucent speaker, and she has a very interesting history and story. She's a family medicine physician. She got her MD at Michigan State, did her residency at Montefiore in the Bronx, and then did a fellowship, actually with a geriatrics focus at UCSF. She worked at UCSF for many years in leadership roles, including the chief of medicine and the service at UCSF San Francisco General Hospital. And then she moved to the East Coast to work at the Robert Wood Johnson and University of Medicine and Dentistry at New Jersey Medical Center, and moved through roles as the Associate Dean for Community Programs and moved up into the role, finally, of the president of the UMDNJ Medical School, which has subsequently been morphed into a joint venture with Rutgers, and she is now serving as the Vice Chancellor for Interprofessional Programs within this medical center and within Rutgers University. She is also the director for the Rutgers Urban Health and Wellness Institute, and we are delighted to hear from her today, and she's going to talk about using our leadership roles basically to advance a justice agenda. So thank you very much for joining us.
Thank you. So my history is almost as confusing as it sounded, and I will actually explain a little bit more about it during my talk. So this is an unusual talk for me, so I'm kind of testing out something here with all of you, and we'll see how it goes, because I want to sort of lay some framework about how I have thought about leadership over the course of my career, wax a little philosophic about it, and then hopefully have time to have some conversation, which hopefully will be the most important part of this. But I want to start with this. So I want to start by looking a little bit backwards so that we can then look a little forward. And as most of you know, last year was the 30th anniversary of the Secretary's Task Force report on Black and minority health. And when the report came out, there were 6 causes of excess mortality that were identified. This data was based on health outcomes from 79 to 81. But the report came out in 85, so very soon after the report came out, a 7th cause, I should say, of excess mortality was added to the list, HIV/AIDS. And as I said, it's been 30 years since that report came out. But if we look at where we are today, we see that some things certainly haven't changed a lot. And we certainly see that excess mortality in African Americans in the United States continues to be an ongoing significant problem. We see, obviously, that accidents and motor vehicle accidents are a significant problem for Native American populations. We see disparity in suicide amongst whites, and I would suspect this updated data probably looks a little bit worse even than this, but we certainly continue to see a significant disparity in death from HIV and homicide in African American populations. We continue to see significant disparity in infant mortality. We've seen this disparity actually since the time that we've measured health statistics by race, and continue to have a great deal of difficulty in managing that. And so, not surprisingly, it means that there are some people that live longer and have higher quality of life than others. This is just to remind us of that. And this is also to remind us that that then translates into people living sort of shorter lives as well. So this is what a cell phone looked like in 1985 when the Secretary's Task Force report came out. And this is what a cell phone looks like today. And this is what the president looked like in 1985 and his wife. And this is what the president and his wife looked like in 2015. And so one can create an incredible narrative about the enormous strides that we've made in this 30-year period of time in technology. We've made enormous strides, even though sometimes it doesn't quite feel as much, but we've made enormous strides in race relations in this country that go from Ronald Reagan to Barack Obama as president. And yet, when we look at that data, we can't say that we've made sort of similar enormous strides. And one of the things I think it's incumbent upon us, particularly in primary care, is to make sure that we have a clearer understanding about why we have not been able to make such enormous strides. Because certainly, while the change in cell phone has made our lives significantly easier, particularly when you're on call, for those of you who are residents and students, imagine what it was like carrying that thing around when you were on call in 1985. We certainly have not, in the health professions, lived up to the promise that we have made or should have made to the populations that we serve in terms of making the same kind of progress. And so I start with that backdrop because sort of guiding all of my thinking about what we do is a real clarity for me that in some ways we have the luxury of just focusing on healthcare. And focusing on health outcomes. And the second part of that, though, is to recognize that from the 2003 report that came out from the Institute of Medicine looking at unequal treatment, so some of this relates to things that happen in people's lives overall, but some of the disparity we see results from what we do. And so it is incumbent, again, as I think about playing a leadership role in primary care, for us to very carefully look at what is our role in the perpetuation of health disparities. What is our role in eliminating these disparities? And the only way that we sort of talk and think about what our role is to be ever mindful of those disparities, which is why I frequently will start talks reminding us all about these disparities. So a fundamental question that I think we must continue to ask ourselves, the more I read the literature about, all of the disparities in cardiovascular disease treatment and in amputations for diabetics and in cancer treatment and in management of pain and the like, the question really arose, well, what was the role of primary care clinicians in the care of these patients? So if I send my patient with heart disease to see the cardiologist because I think that they made an intervention and they don't get that appropriate intervention, do I not have a role to advocate for that patient? And so on a really bad day, I say, oh, none of those patients had primary care providers, and that's why that happened. It's that if they'd had primary providers, of course we would have appropriately intervened. But of course that's not the case, and a substantial portion of these patients did have primary care providers. And so the second part then of our promise is not only to pay attention to what we do as clinicians, but to pay careful attention to what our colleagues do when we refer them and to really make sure that we take on that advocacy role for our patients so that we make sure they get the best outcomes. So what does this mean? So waxing philosophic number one. I'm getting a little bit of feedback. Is there a way to turn this mic down a little bit? Because it's a little bit loud, I think. And let me know if in the back if you're having trouble hearing me, but I don't want to get too loud for too much feedback. So we need to be extraordinarily competent in our work, but we also need to remain very, very, very humble. Because if you kind of compare us to Motorola, you know, in 30 years, we're clearly not making the kind of strides that we would like to make. The other thing to remind us of, let's see if I can get this to work, is that, you know, part of what we do in terms of making people healthier and live longer, 20% is related to what happens within the walls of institutions like this one, right? And that there are much bigger forces that are impacting the lives of our patients, and that's not to say that we don't need to pay attention to these much bigger forces, but also to recognize that there's only but so much that we're going to do that's really going to change the trajectory of the life and well-being of our patients, unfortunately, often until the end of their lives. We are great at actually miraculously bringing people back from the brink of death. We're not so great at keeping them from ever getting to that brink, and I think that becomes our bigger challenge. So now I'm going to do a little social determinants of health 101, and I do this part to help remind us of what many of our patients deal with. And I have to say, the first time I saw this slide, I was just like completely blown away. So what this slide shows is the annual income for the lowest 10th percentile of the population by race between 2011 and 2013. This is income, annual income. So what we see is that African Americans during that period of time, the lowest 10th percentile, had no income whatsoever. And Latinos had no income until 2013 when, miraculously, they got $1,000 on average. Right? And so if you look at these other groups, so compared to nothing, $10,000 is a fortune, and certainly $15,000 is really a fortune. Right? So when we think about poverty and the impact of poverty on our patients, it's very hard for most of us to really conceive of having no income. But it becomes even more important, if we can conceive of that, to then think about the impact on these families of having SNAP benefits get decreased at the federal level. Because SNAP, for some people, is probably, SNAP and subsidized housing is the only resources that they're kind of getting, if you know what I mean, right? So if we look at wealth, we see tremendous disparity in wealth. And what does wealth really represent? Well, what wealth represents that cushion, right? So if I've got some wealth, if I don't get income for a year, then I have something to fall back on, right? But we also have to recognize that this has impact on life and life expectancy, right? By the way, the other thing I need to mention in terms of that wealth is if we scratch the surface a little bit and look at these racial differences on wealth, a lot of that has to do with the historical legacy of racism. And one of the things we have to more consciously talk about is that historical legacy of racism, because if we don't, then we start blaming people for being poor and living in poverty and in bad neighborhoods and all that kind of stuff. And there are very clear reasons that can be documented for why that happens. Am I okay? Okay. So if we look at the life expectancy for the bottom 10% of male wage earners born in 1920, we see that it was 72.9 years. And for the top 10% of male wage earners born in 1920, it was 79 years, essentially a gap of 6.2 years, right? But if we then move to people born in 1950, we see that not only do the rich get richer, but they live a lot longer. And if you do the math, what you find is that the bottom 10th percentile, right? The bottom 10% of male organs born in 1950, their life expectancy went up by 8 months, and the life expectancy of the rich went up by 8 years. Okay? Money matters. Money matters for not only sort of life comfort, but how long you live, right? So fortunately, they had Chicago on this website, and so we get to see how much money matters here in Chicago. So if you live here in East Garfield Park, you live to be about 72. If you live down here in Washington Park, you live to be about 69. And if you live in the Loop, where I'm moving tomorrow, you live to be about 85. So this is the whole, your zip code is more important, right? And where are we? I'm curious. Right here? The final end. We're right about here, so we're right on the water. So yeah. So unfortunately, they didn't put Hyde Park here, but you know, it'd be interesting to see what that number looked like. Maybe you guys can sort of update the map and put that on there, right? But these are the challenges, obviously, right, that we're grappling with. So then let's talk about education and see what happens with your life expectancy by education. So if you drop out of school, out of high school, you're likely to live 9 years less years than if you finish college, if you're a man. If you're a woman, the gap is 8 years, so you're less likely. Now, why do I show this slide? Well, part of the reason that I show this is in primary care, we have an amazing opportunity to not only talk to people about how do they manage their hypertension, their diabetes, and do appropriate exercise, but we get to say, keep your kids in school. We get to talk to them about education. Those of you who are pediatricians really get an opportunity to do this. Those of us who are family docs who take care of kids really get an opportunity to do this. Those of you who are med-peds people really get an opportunity to do this. But you know what? Those of you who are internists get a tremendous opportunity to talk to the parents and the grandparents of these children about the need to continue education because it matters. And it matters, you know, we want to just say, oh, it matters because it's a really good thing, but it really matters because it affects your health and well-being and your longevity, right? So I've been talking about this the whole time I've been here. I've actually been talking about this since it came out. In March of this year, the American Academy of Pediatrics put out 2 reports, one, Poverty and Child Health in the United States, and the other, Mediators and Adverse Effects of Child Poverty in the United States. If you haven't read it, read it. It's at aap.org. It's very easy to find. Basically what it talks about is that poverty has a direct negative effect on early brain development through the mechanism of toxic stress. Surprise, surprise, being poor is bad for your health. The epigenetic, anatomic, and neuroendocrine disruption related to chronic toxic stress may impair learning, behavior, and interpersonal relationships. Now, what's fascinating to me is that scientifically, we're good enough to be able to understand the pathophysiology, but as a society, we're not good enough to fix it, right? So the combination of impaired self-regulation and chronic stress may lead to maladaptive behaviors such as smoking, excessive alcohol intake, overeating, promiscuity, and substance abuse that transiently turn off the stress response, but over the life course may cause morbidity and early mortality. And of course, this is the whole notion of adverse childhood experiences and trauma-informed care. Now, why do I talk about this? Well, one of the reasons that I talk about this is because as the president of AAP is now saying, if we can end poverty in the elderly, we should be able to figure out how to end poverty in children. Now, the difference, of course, between ending poverty in children and ending poverty in the elderly is that it's really, really hard to end poverty in children without ending poverty in their parents, which is what all of us vote for, don't we? And we don't want this child-centric focus that says, oh, it's okay if kids are growing up in these totally poor households as long as they have enough, right? Of course not. And so we really do need to begin a dialogue about ending poverty. And so as I thought about this talk, you know, I'm going to wax eloquent about leadership in a few minutes. But what I really want to say is that in primary care, we are uniquely positioned to talk about what we know. And part of what we know is that poverty is really bad for your health. And so in addition to working with our patients and trying to get them appropriate resources and the like, we also need to lend our voices to the larger social dialogue about these issues. And as I was saying to the students and residents earlier today, we need to have these conversations around the Thanksgiving table and around all of our family picnics so that we can begin to dispel in many people in this country who think that the reason you're poor is because you just aren't willing to work hard enough, some of that mythology, and begin to have people join us in this advocacy to end poverty, because I want to sign up to that. And part of what it takes is moving from a notion of equality, which is what we're semi-comfortable with in this country, to really moving to a notion of equity and saying it isn't just enough to give everybody the same thing when some people have had so much less. And certainly that's the case if we look at reality. And so it really isn't that hard to imagine where we could get to if we just took a few of these boxes and added to the kid who's in the hole in the ground. And yet this is where we are increasingly moving in this country. And as my earlier slides show, this then has a significant impact on the quality of life and the length of life of the person who's living in that hole. Right? So now I'm going to switch gears for a second and talk about you can't know where you're going until you know where you've been. And so I'm going to talk a little bit about where I've been. Come shift with me here for a moment. So, as you heard, I went to medical school at Michigan State. I did my residency at the residency program in social medicine. And as the name would imply, from day one, there was a lot of emphasis on what I just finished talking about, which is that we can't isolate the care of patients from the larger social context in which they are living. And I was very grateful, actually, that the year I started my residency, APHA was in New York. And so they sent us off to APHA, my third month of residency training, where, of course, my eyes were completely opened wide by this notion of, oh my God, we can actually combine public health into primary care. And so it has shaped my thinking and my work since that time. So then I went to San Francisco General Hospital, where I met Dorian. And I started out with, sometimes retrospectively, I think I had like the perfect job because I had no administrative responsibilities whatsoever. I did 50% patient care in a community clinic where Dorian and I worked in an African-American neighborhood, and I did 50% precepting students in the family health center. No administrative responsibility, what did I know? But I had aspirations at that time. So after being there for a while, I decided that the one job that I wanted was to be the program director for the residency program in social medicine. And I just found this picture. I literally found this picture online when I was looking for something else. So that's me, believe it, youth, right? Such youth. Now, I will tell you, and this is the God's honest truth, it was not until I found this picture online that I realized how isolated I was in that grouping. I did not feel particularly isolated in that grouping, I must confess. But to look at that picture and see that I decided I was going to be the person who headed that program, I thought, oh my God, the audacity of youth. That is my frame. So I did become residency director. I was director of the family medicine residency for 8 years. And it was one of the most fulfilling jobs that I had. But what made it even more fulfilling is this is who followed me as residency director. So the other lesson for us is that when we take on leadership roles, we get to open doors for other people and other notions and other ideas. Because by the time Teresa Bielo was residency director, nobody thought twice about having a woman of color as the program director. And subsequently, of course, she too, like me, became chief of the family medicine department at San Francisco General Hospital. And I subsequently became chief of staff of the hospital for 2.5 years. And so was able, in a very interesting period of time in the 90s, to oversee the hospital as it began to make its first foray into what we now call managed care. But again, sort of even doing that, didn't really occur to me that that's not something I should be doing, and I thought, cool, let's do it. Didn't aspire to that one, though. So this is a quick story about my journey to becoming the fifth and final president of the University of Medicine and Dentistry of New Jersey, which I will say is totally hampered by the name. I mean, who would name an institution the University of Medicine and Dentistry of New Jersey? Yeah. So we all call it UMDNJ, but nobody could do that because, you know, it doesn't sort of trip off the tongue easily. So when I left San Francisco, I went to Robert Wood Johnson Medical School in New Brunswick, and I became Senior Associate Dean of Community Health, where I really got to put into practice all of those things that I'd been teaching about for years, about how to partner with communities and work with communities. And for the first couple of years of my job, I actually didn't involve students and residents at all, because I didn't want the communities to become suspicious that my motivation was really about educating all these students and residents and not about helping them to improve. And so I really did, my first year, I almost did nothing but go around and meet various community leaders and to establish credibility with them and learn to partner with them on their initiatives. And then over time, we developed an initiative called Healthier New Brunswick 2010. I'm happy to say Healthier New Brunswick continues. We didn't make the city entirely healthy by 2010, so they dropped the numbers and decided we won't set ourselves up for failure by then saying we'll do it by 2020. But I am happy to say that there are some health outcomes that have improved, and there are a number of health initiatives that we started that continue. So in 2005, the president of UMDNJ, the new president, John Patillo, invited me to become the university chief of staff. And so I said, oh, I'm going to take that job because I'm going to infuse community into everything, right? So I can move out of just my little New Brunswick Robert Wood world and go into Newark, because we have a number of schools in Newark as well, and we're going to just do community health. Well, so the best laid plans. In September of 2005, I go up there, and December of 2005, we got a federal monitor because we had some billing irregularities in our hospital. And Chris Christie, you ever heard of Chris Christie? Give me a break. He's our governor. But at that time, he was a U.S. attorney, and he was threatening to close the university if we didn't take on a federal monitor. So I became the liaison to the federal monitor. Spent more time with lawyers than I ever wanted to spend in my entire life. I thought, oh my God, this is really terrible, and got this completely skewed view about sort of how the world works, because all we did was focus on people doing bad things. Well, in that process, of course, the president lost his job because, you know, somebody has to take the fall. But the senior vice president for academic affairs also lost his job. So after the president lost his job, Bruce Vladeck, who was the former CMS head, Medicare and Medicaid, came in as the interim president. So when Bruce came in, he said, so, Denise, what do you want to do? And the first thing I said was, I don't want to be the liaison to federal monitor anymore, because that's like not fun and, you know, not a good use of my skills. So again, kind of just thinking outside the box, I said, I want to be the senior vice president for academic affairs, but I also want to bring in the clinical units, because it doesn't make sense that they have separate reporting structures. So I said, I want to reconfigure the job and be executive vice president for academic and clinical affairs. And he said, okay. So I said, okay. So I did that up until the university went away, and then when the interim left, Bruce Vladeck came, Bill Owen came, and then when he left, I became, whoops, I think I did two at once, I became the president. So this is how long UMDNJ lasted. These were the 8 schools. So the deans of these schools all reported to me. We had 3 medical schools, dental, nursing, health-related professions, graduate schools, right? So people hear UMDNJ and they think we're just a little rinky-dink kind of medical school. We're really a pretty big institution. These were the clinical units, so the heads of all these clinical units reported to me as well. So we had big hospital, University Behavioral Health Care. Broadway House was actually, is actually a nursing home that was developed for people with HIV. Specifically, fortunately, it's now having to broaden its scope because we don't have as many people with HIV who need to be in nursing homes. So that's like major progress that we're happy about. Our Cancer Institute, the faculty practices in the Eric B. Chandler Health Center, which is a federally qualified health center in New Brunswick that I saw patients in until very, very recently, and that I had oversight of when I was Senior Associate Dean for Community Health. This is what our numbers look like. This is what our budget looked like. Trust me, while you think $1.4 billion is a lot of money, when you're having to balance the budget, it really turns out it's not all that much, right? And I learned that quite painfully. So then the university gets restructured, and UMD&J, this is my nostalgic UMD&J picture of the building. My office is actually still in this building, went away, and we became part of Rutgers. And Rutgers created a new unit called Rutgers Biomedical and Health Sciences. And so I'm now Vice Chancellor for interprofessional programs at Rutgers Biomedical and Health Sciences. So that was kind of my little journey. And the Board of Trustees of UMD&J, in their last board meeting, passed a resolution that took the interim off of my president title, retrospective to the time that I took on the job, and so I get to claim and was the last president of UMD&J. So I was very thrilled with that honor, but quite frankly feel like I earned every word of it given what I went through to merge these two entities into each other. So it's all about the patients for me. And my fundamental belief when we think about leadership is, what do we really want to focus on? And the easy one for me in an academic health center is it's all about the patients, because think of it this way. So a lot of people criticize me because saying, oh, we're a teaching institution, it should be all about the students, right? But we're training students for a purpose, and you saw the diversity of students that we trained at UMD&J. And if we keep in mind the patients, then we say we need to make sure that our students have the very best education they possibly can get so that they can do the very best job for the patients that we want to serve. We need to make a reasonable life for our residents and for our faculty. And people need to feel valued and rewarded, so they do the very best job educating the students to then go on and take care of the patients. And so I infuse this throughout the university. And I infused it also in my own thinking about how to make hard decisions. Basically saying, when I'm stuck with a tough decision, what decision am I going to make that's in the best interest ultimately of the patients? And I found that to be very useful. I also found out that this is true, that a crisis really is danger and opportunity, and I have lived through both. I have certainly seen that danger, having a federal monitor and all of the craziness that goes along that, people losing their jobs and the pain of it. But there were also opportunities for us to come together and regroup as a university, and quite frankly, to learn to do some things better than we had done them before. I'm actually a fairly big fan of Peter Drucker's. I read his stuff on leadership. And Peter Drucker says, trees die from the top. And I'll tell you a secret. So I have a good friend who's like a tree person. And apparently trees can actually die from the bottom and the top. But we won't go there for the purposes of this lecture. But in case those of you, there's some of you who like really know that trees can also die from the bottom, I get it. But, so trees die from the top. What do we know? If you have dysfunctional leadership in an organization, it's very, very difficult, if not impossible, to have a functional organization. Leadership matters. The tone of leadership, the message of leadership, the way we think about leadership matters at every level. And so I pay a lot of attention to what's going on at the top. I'm also a big fan of Jim Collins and his notion of both good to great, BHAGs, all that good stuff, but also great by choice. And so a framework that's in Great by Choice, if you haven't read it, talks about fanatic discipline, productive productivity, empirical creativity, all to get to your level 5 ambition. Right? I'll tell you a secret. Our level 5 ambition is to change the numbers I started with. That's the first part of our level 5 ambition. The second part of our level 5 ambition is to get this country's health outcomes as good as health outcomes in other parts of the world. Because we're busy measuring the health outcomes of people of color against white people, And white people actually don't have that great health outcome in the United States. All these people who talk about, oh, we have the greatest, health system in the world, and blah, blah, blah. Well, we have the most expensive, there's no question, but if you look internationally, not so much. So we're going to have 2 levels of level 5 ambition, right? But again, in healthcare, not that hard to figure out what it should be. So productive paranoia. Now, when you read this, though, think about this in the context of your work. And that's what I was really fascinated to find, is that there's a significant relevance to what Collins is talking about, even in healthcare, right? So productive paranoia is the ability to be hypervigilant about potentially bad events that can hit your company and then turn that fear into preparation and clear-headed action. Let's translate that into healthcare, right? What are the bad things that can happen to our patients, right? And how do we work with them so that they can do preventive stuff, so they can be prepared if bad things happen, so that they can have an ability to mitigate those bad things happening, right? So we all need a little bit of productive paranoia. We need empirical creativity, which really says that when we are creative, we need to actually be more evidence-based in what we do. And certainly we spend a lot of time in academic health centers talking about the need to be more evidence-based. And part of our challenge, of course, is to create more evidence as we go there and stop relying on opinion, like we got to do it this way because we've done it 100 times and that's the way we've always done it, right? And then we need to talk about fanatic discipline. And fanatic discipline is the thing we struggle most with within healthcare, right? Which is really saying that every patient is going to get the same level of evidence-based care, and we're not going to have a lot of personal deviation in terms of figuring out whether or not people need beta blockers after their MIs, or in what ways we're going to treat diabetic patients, and when will people get HIV. Because what do we know? We know this variation actually leads to these bad things happening to patients, right? So then, a few of my favorite leadership sayings. You get the best efforts from others not by lighting a fire beneath them, but by building fire within. We do better when we have passion about what we're doing. Let's face it, there's a lot of stuff we do that we can't be passionate about because it's just like hard work and it's got to get done. But we need in our lives little kernels of passion because that's what keeps us going and able to do the other stuff. And I really do believe that a great leader inspires people to have confidence in themselves. Right? It's all about building human capital, human capacity, if we're truly good leaders, in my opinion, great leaders. And this is my favorite from the Tao. So the very highest is barely known. Then comes that which they know and love. Then that which is feared. Then that which is despised. The leader you despise, you know best. You spend the most time thinking about. You spend the most time dealing with. What do we aspire to be? We aspire to be the very highest that's barely known. He who does not trust enough will not be trusted. When actions are performed without unnecessary speech, people will say, we did it. And isn't that ultimately our goal as leaders? Is to have people feel like they collectively engaged in actions that led to improvements, and not that we made it happen. And of course, we go from the Tao to the no asshole rule. That's often a joke for people that I sort of go from such high, lofty talk. But both are equally important to me, and I learned this from working with a lot of assholes. And I have sworn that I will never do it again in life if I can possibly help it. I'm not being as successful as I would want, but in academic health centers, we have a very high tolerance for assholes. And if you read this book, it makes the business case for how destructive they are to moving forward our agenda. This guy, Robert Sutton, is a business guy. This book came out of a series of articles he had in the Harvard Business Review. This is not sort of some made-up stuff. I urge you to read this book, because the other thing is, if you work with assholes, it has ideas on how to deal with them. So that's worth it. I'm wrapping up here, so stick with me. So without change, there would be no butterflies. That's how I have thought about all of the transitions in my life. So I am now in my next butterfly phase. And so part of what I'm doing is going back to my roots. So we have in Newark a Culture of Health grant from the Robert Johnson Foundation for a project that we are calling Believe in a Healthy Newark Initiative. And these are my partners in this. And we have wonderful partners, most of whom actually don't do a lot of health stuff. They do other things. So the Urban League is involved in community development and in jobs and in providing child care. And the Strong Healthy Communities Initiative is involved in sort of helping to develop community gardens. But right now, a big push of theirs is developing community schools, so that these schools become resources for the families that live in the neighborhood. I won't go through the whole list, but these are the people that will help us to deal with many of the challenges around the social determinants of health. Because quite frankly, as healthcare professionals, we're not really all that great at doing it. But part of what we're going to do as our project is to use NowPal that you guys developed. And I learned about when I came here in 2013. I was like so excited when the folks from NJIT who were partnering with around an initiative to improve patient navigators and community health workers and bring them into Newark said, oh, we're going to try to get NowPal. And it was born here, and you guys did it, and Stacy Lindau and her whole lab. And I thought, I know this program, you know? And that was totally cool. And I thought that I would end on that note, because the world is circular, and there really are only 6 degrees of separation, and it's all very cool and interconnected, but we still have a lot of work to do. And it's all about the patients. So, questions, comments, thoughts, disagreements? This is the time.